that would help us tremendously. So again, I'm Dr. Lucia Boschel. I've been with IU Health for about 8 years now. I feel old when I say that out loud. I want to thank those of you who are joining us. No, it wasn't mine. It's okay. She's putting it on silent. It's fine. She didn't do it on purpose. We won't throw you out, I promise. I'll tell the bouncers to chill out. All right, so for those of you who are joining us today from IU West, IU Ball Memorial, and IU Blackford, welcome. Thank you for this year. I want to let you all know, in case you didn't, that we are celebrating the 10th anniversary of the Fairbanks Center for Medical Ethics and our Clinical Ethics Fellowship Program, and that for us is a very exciting time. To date, we have trained over 50 fellows, and that is noteworthy because today our speaker actually is one of our past ethics fellows, which we're excited about. And it honestly is my pleasure and privilege to introduce to you Robyn Axel-Adams. Robyn is currently the program manager for the Fairbanks Center for Medical Ethics. Before taking that position, she worked at IU Health Ball Memorial Hospital as a staff chaplain for several years and with the Palliative Care program there for about a year. She did her chaplaincy training at then Clarian, now IU Health, and her master's degree from Emory University in Atlanta, Georgia. She did her ethics fellowship training here in 2011 and 2012, as I mentioned. She's going to tell you more about that. And she focused on developing a curriculum for teaching internal medicine residents and about medicine and spirituality. She's married and she has 2 children. I did tell her, I gave her fair warning, I'm an ad hoc person. And I will also tell you that she is a former pastor, and she assures me that she can talk as long as we have time for her to talk, but there is a clock in the back of the room, and she will be mindful of the time. So please join me in welcoming Robyn Axel-Adams.
Thank you so much. My work today does come out of my experience with my ethics fellowship, where I did research on physician education around the issues of physicians talking to their patients about spirituality. And then IU Health Ball Memorial Hospital was so gracious to me, and they allowed me to practice with their physicians and with their staff a lot. And so I did a lot of education initiatives there, continued to work on this work. And before I could do any of my work, though, before I could teach physicians on how to talk to their patients, or staff, anyone, on how to talk to their patients about spiritual issues, I knew I had to make the case. I knew I had to say that this is why you can do it and it's okay. And so probably a better title for my lecture would be, instead of the benefits of inquire, it might be the case for inquiry. But changing your lecture title after CME paperwork has been turned in is about as hard as changing your sermon title after the bulletin has been printed. So I should probably call this the case for inquiry. And so I have to also say that I have no conflict of interest. But I want to start today by reading you a blog. And if you're saying, a blog she's starting, that's really high-quality work you got there, Robyn. This blog is from a writer of the New York Times. His name is Dr. Robert Kiltzman, and he teaches at Columbia and is a physician at Columbia University. And he wrote this blog just a month ago, and it says, "Doctors fail to address patients' spiritual needs." And so he begins his blog this way. "My patient, a woman in her 20s with cancer, was doing poorly on chemotherapy. The disease had spread throughout her body, and we were doing everything we could to help her, but we didn't know how long she had to live. Probably only a few months at most. Her mother came regularly to visit and sat by her bed. Around their necks, they both wore gold crosses on tiny gold chains, and taped to the wall near the foot of her bed was a greeting card with her picture of Jesus in a red cloak with pointy gold beams radiating from his head. She was confined to her room, a prisoner in a sense, and I felt bad that I could not offer her any better treatment. So I wondered, should I call the priest? Should I ask her if she wanted to see one? I wasn't sure. I didn't even know how to raise the topic. I was raised Jewish, and I had no idea about when to call a priest or what doing so might imply. I feared that if I raised the issue, she and her mother would feel that I was giving up on her. So for a few weeks, I did nothing. But every time I visited her, I felt bad. Do we ever call a priest? I finally asked my resident one day in the hall, trying to sound casual. I felt uncomfortable asking, as I should have known better. I occasionally noticed a priest in white collars and rabbis wearing yarmulkes or black hats riding the elevators and walking the halls, but was surprised to find that other doctors and I simply ignored them, never speaking to them. They operated in an entirely different world. My resident looked at me as if I was nuts. This is simply not something that we did as physicians. Senior physicians, and I never mentioned religion and spirituality on rounds with any patients. In the world of scientific medicine, these topics were taboo. And yet it felt odd to do nothing. I sensed her loneliness and her terror in that room, even though she was with her mother. But none of us ever tried to address these feelings in any way. Religion was never discussed in any medical training. In medical school, a priest dropped or maintained a small lounge providing coffee and tea where students could sometimes drop in to get coffee, but that was wholly optional, and most students never did so. And so this brave doctor is sharing about his own struggle with talking to his patients about spirituality. So I say, yay, there is plenty of room still for the work that we do. So before we kind of go and venture much further, we have a little bit of audience participation. I do need you to talk back to me, and I will be repeating what you say. But we need to define the terms that we're talking about today. We need to define the terms of religion and spirituality. They're two distinct words, and yet they're very much intertwined. And it's important that we understand these terms so that we can understand what our patients might be talking about. Some people might say that they are spiritual but not religious. I hope that you don't meet many people that say that they are religious but not spiritual. However, I have met some of those people. And there are so many different definitions of both of these terms. They're not easy words to define. They're about as easy as pinning Jell-O to a wall. But let's see if we can pin at least a little bit of the Jell-O to the wall. So, if we try to define them, spirituality, this is the audience participation part. How would you define spirituality? And I've got plenty of chaplains in the room, so they can help me out if nobody else does. Go for it. Spirituality is your worldview. Okay. Anybody else want to take a stab? Any of my chaplain friends want to take a stab? Personal connectivity to God. Meaning and purpose. Yes. All of these are great. Yeah. A larger sense of self. A belief in a higher being. I think all of these are really great definitions. And so, this is not any official definition. It is just to say it's a broader term. It's about purpose, direction into people's lives. Spirituality has sort of been seen as a new age sort of thing. But spirituality, the term spirituality is about as old as the spirit itself, which many will tell you is ancient. Spirituality really has to do with the person's search for ultimate meaning in life, through sometimes participation in religion, and sometimes they find it in a relationship with a higher power expressed maybe in nature or in rationalism, humanism, the arts. So Viktor Frankl defined spirituality as the essence of our humanity. And Christina Pachowski, who is sort of one of the world's leading experts as a physician on spirituality and health, says that I see spirituality as that which allows a person to experience transcendent meaning in life. All right. Now, what about religion? How would you define religion then? If we said that spirituality is the larger, how would you define religion? Dogma. Tradition. Yeah. A story about which God you believe in. Mm-hmm. Exists within a community. Right. Yeah. I think all of those terms are exactly right. That it's more of a communal thing. It's a specific stories. It's about kind of maybe hands-on, tangible. Sometimes it's through ritual. I found it interesting that a study that was done about 10 years, or in 2002, found that if people who were asked to self-define themselves, either spiritual or religious, the term spirituality was associated with those people who were younger, and the term religious was associated with those people who were older. That's 2002 is a long time ago in study terms, and so I'm going to be curious to see whether that trend changes as we have maybe more of the hippies as they become older. These are just terms that it's helpful to become familiar with as we understand what people talk about and as we decide to converse with them. So then the question becomes, to inquire or not to inquire? Should we even be meddling in someone's religion? This is a huge topic. Some say that we should not talk to patients about spirituality, and there is a larger majority that say that we should. Obviously, I'm going to come before you and make the case that we should, but it is important to look at why people say that we shouldn't. So we're going to kind of look at those first. So I'm going to break this down into three ways: what the published literature says, what the people who are saying no, we shouldn't touch it, what patients themselves are saying why maybe physicians don't talk about spirituality, and then why the physicians themselves say they don't talk about it. So the published literature says that there is supposed to be a separation between health and religion, and it's a boundary that we just shouldn't cross. Physicians don't have time. Physicians are not trained, and so it's going to sort of trivialize spirituality. It can be seen as coercive, and religion is a private matter, so you really shouldn't delve into it. Well, the patients think that physicians don't ask because they're just plain too busy. They don't want to offend anyone, and the physicians lack the training. So why do physicians themselves say that they don't ask? Well, their fear of projecting their own beliefs. They lack time. They lack training. They say they're not sure who would welcome it. They say that, well, I think a patient will bring it up if they want to talk about it. And they might open a Pandora's box. So I'm about to make some counter-arguments, and most of my presentation today is going to be research-based, but this is absolutely what my counter-arguments are absolutely not research-based at all. This is just sort of my own personal arguments. So a boundary not to cross, and yet my contention would be that physicians cross boundaries all the time. As soon as my physician asks me about my sex life, that is crossing a boundary that I don't like to talk about. Everyone has different boundaries that they don't want to talk about, but physicians do it all the time. They ask my child whether he's wearing a helmet when he rides his bike. Those are boundaries that some people just don't want to have crossed. And so to say that this is a boundary we don't want to cross, why is it okay to cross some boundaries and not others? Time. Physicians say they just don't have time, and I acknowledge that. I have worked with so many physicians, and you don't. You don't have time. And right now, you can't code for these visits. There is no religious conversation coding. However, if Medicaid or Medicare can help us out here with end-of-life conversations, you might be able to wrap some of this conversation in end-of-life conversations, and then you might be able to code for it. But research has shown that if you just let someone talk for an open conversation, that it will add about 90 seconds to a conversation. Now, that's not everyone. We know those chatterboxes. But, on average, it won't add that much time if you ask someone about their spiritual background. And it will pay off in the end, and I'm gonna address that in a little bit, because some time that you build in ahead of time might save time for you later. So physicians and staff say that they are not trained. And my contention would be that my goal, as when I taught any physicians or any staff member, was not to turn that person into a chaplain. One of my favorite sayings that Daniel Salmasi said, that this is not neo-shamanism here. But what we're trying to do is to help physicians or any staff member train their ear just enough to be able to hear and understand that maybe what's going on is a spiritual issue. And we don't ask you to then maybe delve into those deeper conversations, but maybe what we ask you to do is refer. Just like if a patient were to come to you, and now remember, I'm not a physician, so please, physicians in the room, don't correct me, but if a patient were to come to you and say, I have this pain on my side, and every time I eat fatty food, it kind of flares up, and I don't feel so good. You're not going to think to yourself, I don't know how to do a gallbladder surgery, so I'm not going to refer them to the physician. You would say, it sounds like you have gallbladder issues. Let me refer you to a physician. The same holds. We're not asking you to have deep theological conversations, but if you start inkling that there might be some theological issues going on, then you can refer to the chaplain. There are also a lot of resources out there now. This field is booming around physicians' conversations around spirituality. There's almost every journal article that you might subscribe to has probably had something in the last couple of years about it. The George Washington Institute for Spirituality and Health, which is what Christina Pachowski runs, their website, the gwish.org website, it has tons of material on educating yourself. And so there are ways out there that physicians can work on educating themselves. Again, maybe not to have those deep theological discussions, but to at least train your ears a little bit better to know when it might actually be a theological argument or a theological discussion. So fear of projection, and that is a really valid fear, and I'm glad that that's a fear, because you have an entirely different kind of relationship with patients than most people do as a physician. And so you don't want to project your own beliefs upon them, and you don't want them to feel like their care is contingent upon their own spirituality. So there are ethical guidelines, and there's articles out there about ethics and spiritual care, and I have an entirely different lecture that I do about ethics and spirituality. But the big issue is that it's about the patient, and it's not about you as the practitioner. It's not appropriate to proselytize. It's not appropriate to make them feel like what they believe is wrong. It is appropriate, though, just to inquire. I had a friend of mine who put on Facebook that she thought it was a little weird that when she visited a new doctor that the doctor asked her about her spirituality. She is not a religious person at all. And I emailed her back, and I was so excited. And I said, tell me how your physician did it, because this is really exciting. I don't know how physicians just do it in an outpatient practice. And she said, well, Robyn, I wasn't offended by being asked on the form about whether I had any spiritual beliefs, but it was the Christian music that was playing in the waiting room. And I said, oh, yeah. The doctor overstepped his boundaries in that area. So Christian music in the waiting room, not a good idea. Asking on a form if you have any spiritual practices is very appropriate. So physicians say they're not sure who wants it. Just know that it's okay to ask. People are not offended by your asking. I'm going to show in the statistics in a little bit that people say if they don't have any religious beliefs, that they don't mind being asked, just kind of move on. And so if you're not sure who wants it, people say that they're not offended by being asked. You might open a Pandora's box. You might actually learn something. Well, you might, and that's okay, because it's better to learn it sooner rather than later. Because if a patient has a religious belief that is going to impact their medical decisions, you probably want to know that up front instead of in a crisis. And so this allows you to hopefully avoid a bigger crisis down the road when it might rear its ugly head. And then this way also, if you know it up front, you can have deeper discussions than you can when you're in crisis mode. And then the physicians have said, well, patients, if they want to talk about it, they'll bring it up. And it's just not the case. It's not the case that physicians will bring it up because they think, or that patients will bring it up. Again, let's go back to why they say that they think you don't ask. Well, they think that you're too busy, and that because you're not trained, or because you don't want to offend someone. So if they have those thoughts in your mind about why you don't bring it up, then they're probably not going to be bringing it up yourself. Sort of as a tangent with this, a Mayo Clinic study a couple of years ago showed that 40% of patients who were admitted into the hospital wanted a hospital visit, but did not think they needed to ask for the chaplain to visit them. So if 40% of people think that they don't need to ask for the chaplain to visit them when they are admitted into the hospital, then they're certainly not going to bring it up with their physician. That's my assumption. So those are sort of my not research-backed ideas about why my counter-arguments. But I think that there are a lot of arguments about why they shouldn't, but I think each of those arguments can be batted against. So instead, let me make for you the case for inquiry. So let's look about why we should inquire. Well, first of all, it's really because we care for the whole person. A person is more than just their disease or their symptoms. Pew Research Center's The Religious Landscape Study, which was just released this past May, indicated that 71% of Americans describe themselves as Christians, and 6% of Americans indicate that they do identify with a faith group that is non-Christian. So we have 78% of Americans that say they are attached to some religious organization. Now, again, that doesn't include those people who are spiritual. Pew has not yet asked that question. But people do claim to be connected to a religious affiliation. And so we need to think about the fact that if religion is a part of a person's life, then you need to talk to them about that part of their life. Religion and spirituality is a huge part of a person's life, and if you ignore that, then you're missing out on who the patient is, because a patient wants to be seen as a whole person. Now, while I have done my research, I have totally focused on the patient and the physician relationship. But the more I have been around Lexi Torkey, who has done so much research around this idea of surrogate decision-making, and then a research study that just came out and was part of it was published in Time magazine a couple of weeks ago, I was reminded that we do need to look about surrogate decision-makers' spirituality and their own needs around their spirituality being addressed. And so this the study that was just came out says that 78% of surrogate decision-makers say that spirituality and religion is fairly to very important to them. So it's not just patients that we look at as whole people, but the surrogate decision-makers that we need to look at as whole people. And so Daniel Salmacy, who is part of the Order of St. Francis and a physician, he just recently lectured at Emory University. He's a physician and ethicist up at the University of Chicago. Says that if healthcare professionals are to value their patients as persons, then they have an obligation to be respectful of the respect of what is important to them. To ignore the religious beliefs of a religious person is to ignore the patient. So another reason that we should pay attention to a patient's spirituality is because it does affect healthcare decisions. A study found that as many as 45% of adult patients indicate that their religious and spiritual views would impact healthcare decisions. And 41% of the public said that religious beliefs would be very important in guiding their decisions about medical care if critically injured. And so people are saying that their religious and spiritual beliefs do affect their healthcare decisions. So what sort of decisions are we talking about? We're talking about everything from contraceptions to abortions, prenatal testing. I don't need to read the list to you, but some of the fundamentals that might happen in an outpatient type setting. What Lexi has found, or Dr. Torkey has found, for surrogate decision making, it's not about these issues. It is more about end-of-life issues for surrogate decision makers. So before I move on, are any of these sort of strange to you, or do you need explanation about how religion or spirituality might play a role in any of these? I just want to make sure that... Okay. So these might be more in, especially the first couple right there, are more in the outpatient setting. But if we think about where it becomes more important to patients, it really is, the decision-making really does come about level of aggressive care. So this is a study that was done by a group. I don't remember where they're from. Lexi Balboni, where is he from? Harvard. That's right. A study that was done at Harvard that talked about the decisions that are made and the level of care that is provided about a patient and for those people who consider themselves spiritual. So for those that have high levels of spiritual support from patients from their religious communities, if they have high level of support from their religious communities, they actually get more aggressive medical interventions. They have greater ICU deaths, and they have less hospice care. However, if a person receives spiritual support from the medical team, and it did not matter who on the medical team, it could be physicians, it could be nurse, it could be social worker, it could be chaplain, then those trends are reversed. So let's see if I can help you understand this graph here. So what we have here is and I'm going to have to bring up mine a little closer, is that the darker parts here are, let's actually start with the lighter one. The lighter ones are those who are considered who consider themselves highly religious and who have had no sort of spiritual care conversations. And so these are the number of people that receive hospice care. So you can see that the number is lower. But if they have a conversation if they just have either an end-of-life conversation or a religious conversation, that's what this middle one is. It doesn't have to be both. It's just one, end-of-life or a religious conversation. Then the number of people who receive hospice care goes up. But if they have both conversations about end-of-life care and religious care, then the number, to me, jumps dramatically. And again, it doesn't have to just be from physicians. And so we see that if you have no conversation, those that have hospice care is low, and then it jumps if you have both end-of-life and religious conversations. And so here, the second one, you want the trend to be reversed because this is about aggressive care in the hospital. Again, those who have had no conversation, all the way down to those who've had both conversations. And then deaths in the ICU. High number of deaths in the ICU if you have those conversations. The number of the deaths in the ICU goes down. And these are people who have self-identified as being highly religious. And so, the contention here is that if we have these conversations, and again, it can be anyone in the hospital, but that if the conversations are had, then a lower aggressive care is also followed. There was a study done that's a little bit older than this study here that was done with cancer patients that shows that people who have had religious conversations or feel supported about their religious associations, that they have threefold greater odds of receiving hospice care. And so it's just about being and caring for the whole person, listening to them. So another reason that it's okay to ask a person and why we should ask a person about their spiritual care. Patients are really okay if you ask, and I touched upon that a little bit ago. But research has shown that people are fine with your asking. In one study, 83% of patients indicated that they sometimes or always wanted to be asked about their spirituality. It is interesting to see, and probably not surprising, that the more severe a person gets in their healthcare needs, the more they're okay with it. So if you're just doing an office visit, some people are okay with it. One study showed that about 40% of people are okay with it. But if you have a death and dying issue, then it jumps to 73%. And so it does acknowledge the fact that there are swings in how much people are okay with it. But overall, people are okay with being asked. I found this another study really intriguing, that there was a study that targeted neo-pagans. And 84% of neo-pagans agreed that it would be important for a physician to ask about their religious beliefs. And 81% of the neo-pagans said that it would strengthen their trust in their doctor. And even patients who have no religious affiliation are really okay if you ask. They just, if they say they have no religious beliefs, then you just move on. And that goes back to the proselytizing, what we do not do. So why else should you ask? It really can and does improve the physician-patient relationship. It builds trust, and it shows that you care. In a study, 66% of respondents agreed that a physician's inquiry about spiritual or religious beliefs would strengthen the trust in their doctor. So it really does indicate that a physician cares about them, listens to them, builds the trust. And sometimes the trust that physicians or patients have in the physician is not as strong as it could be. We have lost the age where everyone believes everything that the physician says. One study indicated that 65% of surrogates were reluctant or unwilling to believe a physician's futility prediction. So there's the lack of trust sometimes, especially around end-of-life issues, is not terribly high. So if there's anything that you can do to build trust, that would be especially helpful. But as you continue to build the relationship, it can continue to affect and lead to more effective care. So this is what I was talking about at the beginning when I said that it can pay off later. An initial conversation around a patient's spirituality and health can build that trust so that later, when you're needing to have these conversations, when you're needing to have these harder conversations, maybe they trust you a little bit more. And so they're willing to listen and hear what you have to say so that you don't have to work as hard to help them see what you are seeing. And so, no, you can't code for time, but maybe this is the time that it will pay off. So those are sort of the touchy-feely reasons. If you can't read my slide, it says, I know this hat looks foolish, but it shows that I'm all ears and I'm interested in your concerns. So everything that I have talked about thus far, some might call the touchy-feely reasons for why a physician should inquire into a patient's spirituality. When I was talking about this with one of my initial groups of people that were helping me design some of my long-term plans, someone said, well, that's great, Robyn, but tell me how it affects the bottom line at the hospital. So I know that I need to also include some bottom line things. So we're going to look now about what what some more official bodies say versus those touchy-feely reasons. So why should you inquire? Well, you should inquire because the Joint Commissions actually says that it's okay and that we should inquire. So in 2001, the Joint Commissions added a standard that focused on the provision of care, treatment, and services. It required healthcare organizations to include a spiritual assessment as part of a patient's assessment to determine a patient's spirituality might affect their care. Now, I don't know how it's done all over the place. I have a feeling that sometimes it's done by a patient being asked, would you like a chaplain to visit? Or, what religion are you a part of? Everybody's asked that when they're admitted here at IU Health. That is probably the bare minimum, but the Joint Commissions really encourages this to be done. And they do say that physicians, therapists, nurses, clinical pastoral staff should receive training. And so Joint Commissions is asking us to train people, and yet we're not doing always the best job about doing that. So Joint Commission says that we should inquire and encourages us to inquire. So why else should you inquire? Well, here's where it starts to affect the bottom line. It does improve patient satisfaction. A 2011 study done at the University of Chicago was done with just over 3,000 patients. And I'm going to walk you through these statistics because to help us get to the very last graph. But the statistics, or what this played out, was that 41% of patients who entered the hospital wanted to have a religious and spiritual discussion. Half of the patients who wanted to have a discussion did not have one. This is not the physician's fault. It's not the chaplain's fault. This is just a fact of what happens a lot of times in a hospital. So 32% indicated that they actually did have conversations with a physician, a chaplain, or someone from their own religious community. And a quarter indicated that they did not have a desire to have one, but they ended up having a conversation anyway. Who knows how this happened? I mean, it could have just been a chaplain was rounding and they had a conversation. It could have been a doctor brought it up. They don't specifically say how this quarter had a conversation, even though they weren't planning on it. But so these conversations were happening. So when these conversations were happening, whether the patient had a desire to have the conversation or not, patients felt that they were more satisfied with their hospital stay and in their doctor's care, and their trust in their doctor went up. How do we know this? Because patient satisfaction scores went up. So here's the graph or the chart that I want to show you. So here's how I've broken it up. We have those here that wanted the discussion, and the bottom here that said they did not want a discussion. And again, they weren't opposed to discussions. It's just that when they came into the hospital, they didn't think, oh, I'd like to have a spiritual discussion. So then we have, for those people that wanted a discussion, that did not have a discussion, here's how their scores rated. They were, 63%, so they were extremely satisfied with their doctor's care. But if they had a discussion, it jumped to 71% were extremely satisfied with their doctor's care. Always had confidence and trust in their doctor. Again, those who did not have a discussion, 77%, it jumped to 84%. Coordination, they asked was there coordination between the team? 55% said, yeah, it was excellent. 72%, if they had a spiritual discussion, said that it was excellent. And again, overall, care received is exceptional, 59% versus 69%. For me, the staggering numbers, those are staggering, but the really fascinating numbers are about these that did not want discussions. Those that did not want discussion, again, we jumped from 63% to 77% who were extremely satisfied with their doctor. Always had confidence in their doctor, 78% to 86%. Was there coordination in the teamwork? 57%. Sorry, I'm trying to get my clicker. 57% to 67%. And then we have over here, was your overall care excellent? To jump from 60% to 72%. And so their research showed that when a discussion was had, again, by anyone on the care team, patient satisfaction scores went up. And we all know what happens when patient satisfaction scores go up. Reimbursement rates go up. And so when I first made the presentation on this research, someone said, well, Robyn, I can't code for this, so I can't gain money by coding for a spiritual conversation. But if my patient satisfaction scores go up, then I do get, bonuses for that. And so I can't guarantee that you will get a higher salary because you have patient satisfaction scores. But again, as we think about are there reimbursements that are happening, then this shows that patient satisfaction scores go up. And there are times that it feels very uncomfortable to attach spirituality and religion to finances. And yet, in a hospital setting where we are pressed for time, and people talk about time, and we talk about, our things that we do value added, we have to look at the bottom line. And so this here shows us that patient satisfaction scores go up, which we know does affect reimbursement. And so another way that it can affect the bottom line is one of the last ways that I want to share that why should we inquire? Because it can affect the bottom line. This is another study that was done. I'll tell you, Lexi and I have talked about this, that Balboni and his group has gotten so much mileage out of this one research study. But this research study showed that, again, the advanced patients who reported religious and spiritual needs that were insufficiently supported by their healthcare team, and again, this is all self-reported, and so they don't have a way to regulate or to think out about how people are defining not supported. But if they felt that they were insufficiently supported by their healthcare teams, the medical costs in the final weeks of life increased. And again, we can go back to that one graph that I showed you about, the length of stay in the ICU, lack of hospice care, number of deaths in the ICU. That graph kind of played this out. But what they did then is that they took some numbers, and this was the average cost of aggressive care in a hospital in 2011. And so they just took the average cost in the United States. It was a published estimated cost for 2011. And so what they did is they said that it takes approximately $2,441 more dollars in the last week of life. Again, that's the average. And if we take the fact that they just did this with cancer patients, let me also say that, but if you take the fact that there are 562,340 annual cancer deaths in the United States a year, then they took that number and multiplied it by 2441, and they estimated that it can cost as much as $1.4 billion with more aggressive care. The impact is $1.4 billion, and this is across the United States. Now, minorities and those who consider themselves highly religious, and they have, again, low support that they've received from the hospital staff, their average jumps even more to 4,200. And so the proposal here was that if their religious or spiritual needs were met, then they avoided more burdensome and aggressive medical care at the end of life. And again, the bottom line would totally be affected. So why should we inquire? Just to sort of summarize and putting all of my arguments there sort of on one slide, it's because it does affect healthcare decisions. It affects whole person care. Patients are okay if you ask. It really does improve patient satisfaction and patient relationships. The Joint Commission says that it's okay for you to inquire, and they actually encourage that to be done. It can improve patient satisfaction, and it will affect the bottom line. And so to end, I just want to end by reading the end of Dr. Klitzman's blog. As we started off with him, I will end with him. It says, yet studies have documented the importance of religion and spirituality to many patients. 70% of dying patients want their doctors to ask them about their religious beliefs. And religious beliefs also often affects patients' wishes when it comes to choosing aggressive end-of-life treatment or palliative care. However, only half the patients who want to discuss religion or spiritual concerns with someone in the hospital end up doing so. And over the years, I have increasingly seen how many patients, especially when confronting the end of life, value their emotional, existential, and spiritual feelings over further medical treatment when it begins to become futile. Eventually, my patient dying from cancer, the 20-year-old that he talked about at the beginning, did speak with a chaplain. I noticed him visiting her one day as I walked by the door, and I again spotted him 2 days later heading towards the door. The next morning, I thought that she, the patient, looked calmer, more relieved than I'd seen her in weeks. She still had unremitted fevers and died a few months later in that room, but the chaplain had helped her, I felt, in a way that I and medical treatment could not. I still regret my silence with that patient, but having tried to learn from it, doctors themselves do not have to be spiritual or religious, but they should recognize that for many patients these issues are important, especially at life's end. And if doctors don't want to engage in these conversations, they shouldn't. Instead, a physician can simply say, Some patients would like to have a discussion with someone here about spiritual issues, and some patients wouldn't. If you would like to, we can arrange for someone to talk with you. Unfortunately, countless patients feel uncomfortable broaching these topics with their doctors, and most physicians will never raise it. So, thank you. So, yes, Lucia.
So in the study that you cited, the patients who would have discussion, I'm curious about how a discussion was described, because in order to meet a joint commission requirement, you can document that you asked somebody about it. You simply check a box, and that's the extent of the discussion. Can you say more about what a discussion meant in that study? Were they able to document? Was it just an invitation to talk? Was it a conversation with someone? Can you say more about that?
Sure. They did not go into. Oh, I'm so sorry. Thank you for reminding me. So the question was there more explanation about what a discussion meant on the Balboni study when I talked about the aggressive treatments back? Yeah, there it is. Yes, here it is. About what constituted a discussion and how did they cite that. I will admit that I don't remember if they discussed that a whole lot more. That is something that I'll definitely look up and get back to you on. Do you know enough about? Thank you. Dr. Torkey just said that it was a patient. The patients or patients self-reporting about how they felt they were supported by the medical staff for spiritual care and spiritual addressing. So it was a patient response. So thank you. Yes. Well, so the way that they described themselves, I mean, it was, thank you, Lucia, for reminding me, how to define neo-paganism. So I will say that they defined themselves, but they named themselves, but they did not define themselves. And so how their list of them, as they described themselves, was that there were some that believed in witchcraft, some that believed in more, that they called themselves more spiritual but not religious, some that were more atheistic but had some sort of spiritual background. I mean, they don't go into how they describe themselves very much, but they sort of came up with a few of those terms. So. Yes.
What advice would you have for a doctor that doesn't have a spirituality,
Mm-hmm.
is an atheist, and the patient asks, do you believe in God? How does a physician in that situation, you got any suggestions?
Sure. The question was, how does a physician who is not spiritual address that? And I think that what I have noticed in physicians and talking to physicians is that they choose to do one of two things. First of all, they can sort of explore with the patient, help me understand why this is important to you. Assure them that their care is not dependent upon, whether they agree about any particular faith background or not. I do know that some physicians have absolutely refused to share what their spiritual background is, and they don't do that just for for anyone. That's sort of their blanket policy. And some, they are very willing to share, well, I don't believe, or I do believe. And then assure them that if they're not able to meet their spiritual needs, that they can find someone who can, if the question comes from a desire to talk to someone about spirituality. I do know that there are patients out there who want to make sure they have a Christian doctor, who want to make sure they have a particular religious doctor. And if that becomes the issue, then you probably have to be willing to say, I'm probably not the physician for you. And acknowledging the fact that sometimes we have to change care providers if it is that important to the patient. But to again remind the patient that it's really about them. And so if someone says, well, do you believe in God? It's very appropriate to say, if you are not a believer, or even if you are, state your belief and then quickly change it back to the patient, because it's not about your own beliefs. Even if you are a believer, it's not about what you believe. It's really, again, focusing on the patient. Help me understand why that's important to you. Are you a believer? Is that important? Does it play a role in your life? So, yeah.
Could I clarify about neo-paganism?
I would love to hear how you would define it. I'm not sure if I can expand more on how they define it or not.
It's nature-based spirituality.
So Tim is saying nature-based spirituality based upon the earth.
And many call themselves Wiccans or Druids.
Yeah. So, thank you. And again, I don't know if that's how they define themselves, but maybe that's how you would define it now. So, thank you. Yes.
So, one more question about the study that showed it was less cost. Did they ask the question that identified whether or not the patient's care was consistent with their values? Because what I'm worried about is if we say, oh great, we asked them about spirituality, it'll cost less, but it may not be what they want.
I don't know how to respond to that. Okay, so the question was, were they asked about whether it equaled what the care they eventually got was equal to their values? It's sort of what you're asking. I mean, let me ask this another way, because this is a question I have been asked before, Lucia. Were they being forced to do something, or was this idea that a physician was, in a sense, putting their own spirituality on it, and so a patient was being manipulated in some senses? I don't think that was looked at. That was not examined. We would assume, and again, maybe this is just an assumption I'm making, we would assume that it would, if they were willing to have those. I mean, I don't know. I probably better just stop instead of making any assumptions. An explicit question about if their values, was the care you received consistent with your values? And I think that's not, if it is a question that they ask, that's not something that they have divulged in their. Maybe that's the next paper coming. I'm telling you, they keep publishing papers out of this particular research. So, yes. I'm not. Mm-hmm.
And it's led social work coordinates it, but it's very purposeful that we have chaplaincy, the physician, the attending physician, and then any other physician, consulting physician can be invited to the meeting as well. And of course, nursing and the family. And the goal of this, of course, is to create goals of care based on, oftentimes advanced directives, or
Mm-hmm.
advanced directives aren't known that the family is very much involved in trying to develop what that looks like. And of course, what I love about your presentation is that it's actually showing us some research of what we're being able to develop and explain for. This has only been going on since the 1st of September on 4 East, but we've already seen a decrease in palliative care referrals. We've seen an increase in hospice referrals.
Mm.
We've seen, of course, a decrease in unnecessary testing, unnecessary surgery.
Mm-hmm.
I'm just giving that out that
Yeah.
that might be the connection to the financial. But absolutely an increase in family satisfaction and staff satisfaction, knowing that they're caring for a patient in accordance with what that patient might have wanted if it was a family that they paid for. And the spiritual component that we're also seeing an increase, it's an increase in chaplaincy, participation and guidance in those conversations. And then it's also not just expecting or hoping that physicians are comfortable with that conversation, because like you said a few moments ago, if they might not be, then it gets them to the individuals who actually can.
Right. So let me repeat back for those that are joining us by video. She's giving a fabulous anecdotal example of what's happening right now at 4 East at Methodist Hospital, where they're trying very hard and being very intentional about doing an interdisciplinary team meeting for those patients that are expected to be in the hospital for more than 5 days, including physicians and social workers and chaplaincy. And they have seen an increase in the amount of referrals to hospice, and they have seen an increase in patient satisfaction as patients are. So are patients and family members involved in this care conference as well?
Patients, when they're able to report,
Mm-hmm.
it's primarily family.
So family members are involved in this. It's not just the physician, everybody, the clinicians talking to themselves. So they know that the chaplain and the social worker are present and helping to be involved in those discussions and guiding some of those things. And so, just the pilot study that they've done here kind of echoes and reflects what has been shown in research. So, well, good. I'm glad it's working. Right. Well, and my contention was always that, again, I don't expect people to become anyone else except chaplains to become chaplains. But chaplains are not able to get everywhere in the hospital. We just don't have enough of us. But there is a physician or a social worker or a nurse that sees every single patient every day. And so if they can listen and hear a little bit more about spiritual concerns, then they can make the referrals. And the better the referrals we get, then the better chaplaincy, the better work the chaplains can do. At IU Health Ball Memorial, that's what we found. We found that once our department, the spiritual care department, started working on providing these educational opportunities for our physicians, that our numbers of referrals from physicians increased. And so that helps us provide better care and can target who specifically needs that care. And so that's the benefit. And that Mayo Clinic study that I was talking about, that 40% of people who wanted a chaplain visit thought they didn't have to ask for one. And just kind of expected the chaplain to appear. It's not going to happen. And so if we can get those 40% to be heard by their nurses or their social worker or their physician, or those great clues that doctor was talking about, the necklaces and that little picture on the wall, to even just say, hey, tell me about this picture on the wall. Is that important to you? Our bloggist was writing about, even something simple as that. That's the conversation starter. Oh yes, spirituality is really important to me, and this helps so much, makes me feel so much better when I see this picture. Oh, if you ever get to a point where you would like to talk to someone about that, I can make a referral. They don't have that's the extent of what you really need to do as a physician or as a staff member to help enter that conversation. To get a chaplain, to get the idea of whether they need a chaplain referral or not. Yes, Vern.
Robyn, would you go to the slide that showed that highly religious people without appropriate intervention, the cost is higher?
This one?
One before that, I think. I'm just trying to lift up the reminder that a person can be that has community support from the church and has religious support, but if that doesn't get translated over into how it impacts healthcare decisions, it's not, right, there you go, where the minorities and highly religious coping, it can actually go higher. And as chaplains, how sometimes we see community clergy kind of come in and undo all the work that's been done.
Right.
And you might, I don't know if you want to speak to that a little bit.
Mm-hmm.
I know you've been there, seen that, and all of us have, and maybe everybody else needs to hear about that.
So the challenge sometimes is what Vern is talking about. Vern is our manager of chaplaincy services at Methodist. Is the community pastors or the community people who come in and provide what we might call as support. They are supportive, but as he puts it, sort of sometimes undermine the work that is done. And it is challenging when you have people who don't understand the healthcare setting to come in and talk about what needs to be done in the healthcare setting. And so, your chaplains are highly trained in the healthcare setting to work in the medical area. We certainly don't work in the medical field as physicians, but we work in the medical area, and so we understand and we see so much of what goes on. And the local clergy don't always. And so there has to be this balance of the support that happens because the local clergy are going to be the long-term care. And yet we find that there is times, and there's times that I say, I wish that pastor would get out of the room so I can get in there and do something. That they almost seem as a hindrance or a burden. And so it's painful to say. It's painful to say about my own clergy brothers and sisters But I also know that it's just when you work with it every single day as the clergy that we are, we see it in a different way. And so we should not assume that, oh, yay, their pastor is here, we don't need to call the chaplain. I learned that very early on in my chaplaincy education, where I had a patient who was a long-term patient. And when I realized that her pastor came to visit, I said, you know what, I don't need to visit. It's okay, your pastor visits. And she just said to me, no, you still need to visit me, please. And I realized that she and I could have conversations that she and her pastor could not have. And we could have conversations about her struggles with her faith, because she wasn't going to have to look her pastor in the eye who was going to question why she was struggling with her faith. You know, she and I could have these honest conversations. I call it a stranger ministry, because she didn't know me, and I didn't judge her at all about any spiritual question that she asked. So she asked some amazing spiritual questions, and she challenged me like no one ever challenged me theologically around hospital settings. But, you know, again, I would have gravely erred if I had assumed that because her pastor visits as the chaplain, I did not need to visit her. And when I did my residency, we were then moved over to, I was at Methodist, and then I was moved over to Riley and IU. And when she was about to die, and she knew she was about to die, she asked that I come over and be with her. And so, you know, I just knew the impact that I had on her when she asked that I come back and be with her in her dying moments. And so, you know, don't assume that just because a person has their pastor there, that they're good to go. So, and you have a fine group of chaplains in this hospital. And so they are available and to be called upon. I know that not every hospital who is listening in has that great privilege, but if you can get connected to physician or to the pastors in your community, that's a possibility as well. So, all right, Lucia is walking up, which means we say goodbye.
Yeah, the speaker knows when the introducer stands up that it's time to end. So please join me in thanking Robyn for her talk.